Thank you so much, Dr. Azim and Dr. Junaid. Now we'll proceed to our next talk. Our next speaker is Dr. Shabina Arif. Dr. Arif is a clinical expert in neonatology and community-based research. She is principal investigator of multiple national and international research projects aimed to improve maternal and neonatal health in Pakistan.
Good. Thanks. Thank you. Okay. Assalamu alaikum.
Thank you so much, Dr. Azim and Dr. Junaid. Now we'll proceed to our next talk. Our next speaker is Dr. Shabina Arif. Dr. Arif is a clinical expert in neonatology and community-based research. She is principal investigator.
So, Assalamu alaikum, everyone. Can you hear me? Okay, great. So, I'm not wearing a community hat on anything. I'm going to talk about simple things like ABG, which is simple but yet extremely important to understand, and important to understand from basic point. A lot has to do when you're ventilating a child, when you're trying to diagnose what is wrong with this baby. You want to know what is happening to the physiology at the level of the body, in the lungs, how are the kidneys doing. And the best way to reflect what is going on is the acid-base balance in the body. And if you go back to your previous physiology, the Hasselbalch-Henderson equation, which tells you what are H ions, what are your cations, your anions, your bicarbonate. So we'll try to make it very simple and take you through this interpretation of arterial blood gases. Why is it important? How do you interpret them? And how does it help you in the management, especially when the baby is on the ventilator or a decision has to be made that the baby needs to go on the ventilator. ठीक है? तो ये बहुत एक helpful aid है. Pulse oximetry भी aid है जो आपको oxygenation बताती है, but it doesn't tell you what pH. It doesn't tell you is the body compensating or non-compensating. अगर एक baby है जो compensate कर रहा है और अपनी respiratory muscles move कर रहा है, अपनी kidney से buffer कर रहा है, so you probably would not put that baby on a ventilator. और Dr. Azim ने जैसे कहा कि कुछ babies हैं जो invasive ventilation पे जाएंगे और कुछ babies हैं जो non-invasive ventilation पे जाएंगे. So ABGs actually हमें help करती हैं in deciding where the problem is. Is it lungs? Is it cardiac? Is it the kidney? तीन चीजें हैं ना, ठीक है. दूसरा हमें help करती हैं escalation and de-escalation में. अगर एक बच्चा ventilator पे हो कि भाई अब उसको de-escalate करना है, डॉक्टर साहब ने पूछा कितना PCO2 रहना चाहिए, ठीक है. डॉक्टर अजीम ने कहा PCO2 should be on the higher side. डॉक्टर जुनैद ने कहा yes, but it depends on what mode of ventilation you're using. So what your gases will do will help you in making a decision and also what type of ventilation you're carrying out. ठीक है. So, okay, sorry. So थोड़ा सा the overview of this presentation is basically what are the indication of arterial blood gases, understanding the ABCs of ABG. What do we mean by ABG, and what are the things that you look for when you're interpreting an ABG? ठीक है. कुछ basic terminology की understanding जरूरी है, जैसे physiology of respiratory muscles, physiology of ventilation बहुत जरूरी है समझना in order to interpret, right? In order to make moves on the ventilator. इसी तरह से आपकी जो basic terminology है वो क्या है और उस ABGs में क्या disorders हैं और उनको analysis कैसे करते हैं. थोड़े से case scenario डालें ताकि हमारी भी understanding हो कि what have you classed from this talk. So sort of थोड़ा सा interactive रखने की कोशिश करते हैं, ठीक है. All right. ये आगे नहीं बढ़ रहा. चलिए. So I've alluded to कि भाई indication of ABGs क्या होते हैं. All right. So यही conversation मैंने भी आपसे की. It's a diagnostic tool, ठीक है. और ये बताता है कि भाई what is happening to the pH in the body, ठीक है. What is happening to the oxygenation and ventilation in the body, right? And what is the acid-base status of the body, ठीक है. So आपने pH देखना है, आपने ventilation, oxygenation को check करना है, and आपने acid-base को देखना है. So it basically helps you to understand, you know, respiratory problem, circulatory problem, or metabolic problem, ठीक है. So I think this is a repetition, so I will just move on. So let's talk a bit about the procedure. What is the procedure? Mike, sorry, I'm not sure. So let's talk about anybody.
Where do you do the arterial blood gases from? So the word is arterial blood gases, not capillary, not venous, है ना? तो कहाँ से करते हैं? अच्छा, radial artery, brachial artery. What is gold standard? So like indwelling central catheters, है ना? बड़ों में भी होते हैं central catheters. Neonates में umbilical artery is the main because sorry, umbilical है, very good. So central indwelling catheter से आप ideally करना चाहिए, but sometimes it is not possible, and then we have to use the radial artery. In emergencies, we use the brachial artery. Femorals we tend not to use in neonates unless there are procedures. In adults, of course, you use them. In pediatric age group, you use them. So the most safe is your umbilical artery. ठीक है? अच्छा जी. अब ये capillary भी होता है sample. So capillary sample हम करते हैं for arterial blood gases. Right, we do it, no? ठीक है? So we do it, and we'll see what is how can capillary blood gases be used in management of patients with respiratory disorders such as PPD, where you're concerned more with other things than oxygenation. So what do you do is ideally तो एक heparinized syringe होनी चाहिए. Heparin की use करते हैं हम. Thrombin सही है. तो thrombin 3 factor 10A को inhibit करता है और fibrinogen को fibrinogen degradation product को hold करता है. So the pathway of procoagulant को वो inhibit करता है, right? So that is why heparin होना जरूरी है. लेकिन heparin होना जरूरी के साथ ये you have to understand that you have to flush it with 0.5 ml of 1,000 heparin. If you leave heparin inside, what will happen? Dilutional effect होगा, ठीक है? और dilutional and if you leave it for long, your WBC is going to start using the oxygenation. ठीक है ना? So PO2 will fall. So what you do is you take 0.5 ml of heparin and you flush it out. ठीक है? Very, very important. You flush it out and you make sure residual नहीं हो, 0.000 ml भी नहीं मौजूद हो syringe. ठीक है? And your syringe should have at least, it should be ideally 3 ml syringe or smaller, and it should occupy at least 50% of the volume of your syringe. Okay? See, this is very important, and it should be in a cold chain. Okay?
So ये basics हैं of doing the procedure.
Shabina, 1 second. Shabina, can I ask you, because it is better if we have interaction.
Alnar is working. उसके लिए आने टेस्ट होता है, you all heard about it. आप प्लेज करते हैं, दोनों को प्रेशर यहाँ पे वेरियस रखते हैं ताकि फ्लो जो है स्टॉप हो जाता है, और जब आप स्लोली रिलीज करते हैं अपनी अंदर साइड और फिर खोलते हैं तो देखते हैं if the blood flow comes back because there is a collateral. If there is no collateral, then one should not attempt a radial. This is very, very important. ठीक है? One should not attempt if the collaterals are not working. So this is simply called the ANALYTE test.
These are some pictures of your so in an ideal world you already have syringes which contain heparin, and you can say they are not used for injections. You don't inject with them, okay? But in our setup where we are, we have to put in heparin, flush it out, and then use that particular syringe. And these are the capillary heel pricks that we use, which are very, very small. All right, so you have capillary heel prick, which is IVD on these are the two primary sides. You don't do it on the center, you try to do it on the lateral and the both lateral aspects. You warm it, you make sure it is clean, and you warm it so that there is enough flow. And you're taking the blood from a capillary, which is your connection between the smallest of the arteriole and the smallest of the venule. So remember, it is the end where there is exchange, where your oxygenation level is not going to be good, because here there is delivery of the oxygen and uptake of the CO2. Okay? So if you leave a bubble, और कभी-कभी होता है ना, हम पहले तो जब हम residents थे तो उस वक्त तो
sometimes we need to, sometimes we have like an artery, but maybe from a radial artery much towards it, or have. So sometimes there are bubbles when you're taking out. So with the entry of bubble, what will happen? There will be increase in the PO2 and decrease in the CO2. Common sense, guys. Bubble is there, oxygenation बढ़ जाएगी और आपको एक false reading देगी कि oxygenation is better, right? What are the changes that take place if you're not careful in getting your ABGs in what they call is as a cold change? आप जब भी ABGs देंगे, you make sure temperature maintain हो. अगर आप temperature maintain नहीं करेंगे, ice में नहीं जाएगा, तो फिर there is going to be a change of tenfold. So the pH change with normal temperature is 0.01 versus 0.001. Tenfold आपको false reading मिलेगी. So this is very important because then based on the outcome, जो result आपकी ABGs होगा, उसी पे आप अपनी जो भी intervention करनी हो करेंगे. So make sure that you're doing the right trick. Make sure that you're sending it within 15 minutes to the center, to the place that you want, or your analyzer to analyzers then, and you can do it immediately within 5 minutes of the withdrawal of the gas. And the PO2 that is going to change is also tenfold. So can I move it? So let's talk about some terminology, and I want to learn and understand from you. What do you mean by acid-base balance? What comes to your mind? Anything? कोई भी क्या समझते हैं acid-base balance क्या है? Anything? आपकी understanding क्या है? There should be a balance between the acids in the body and the bases in the body, and that is called as acid-base balance. Anybody else want to try?
Acid-base balance is required to maintain the normal pH effort enzymatic activities being carried at its normal pace.
What Dr. added was that the acid-base balance reflects the pH, and we need to have a normal pH. And what is the normal pH? 7.35 to 7.45, right? So you need acids, you need buffer bases, and you need a balance between them in order to have a normal pH which ranges between 7.35 and 7.4. Okay, so basically the body has a complex process, but it tries to maintain a stable extracellular pH. The intracellular pH is being carried out by phosphate buffers, which are intracellular, and by proteins, which are intracellular. We are not going to talk about them. We are going to talk about the extracellular जो plasma में जो blood draw करके करते हैं. That's your extracellular pH, which governs many functions of the body. So I say, that is why it is one of the most important physiological processes that take place. So the pH is measurement of the hydrogen ion concentration, H ions, and if the H ions are more, what will happen? Very good. Acidosis हो जाएगी. Simple. Let's keep it very simple. ठीक है? Hydrogen ion बढ़ गए body के अंदर तो क्या हो गया? Acidosis हो गया. ठीक है? और alkaline कब होगा? और hydrogen ions कम हो गए और base बढ़ गया. आपके base जो buffer है वो बढ़ गया. ठीक है? Simple. So let's keep it simple. So what is an acid? It's a substance that can donate the hydrogen ion to the alkaline solution. An acid is a substance which will give up H ions to the alkali, in order to keep the pH neutral. Simple. Similarly, acidosis is a physiological state where there is significant increase in H ions or deficit in base. This concept clear? So what is the base? आपने base excess, base deficit लिखा हुआ होता है ना arterial blood gas में लिखा हुआ होता है base excess, base deficit. What do we imply by base excess? Anybody? What is there क्या है पीछे? Anybody? Come on. Base excess क्या है? आपको negative interpret नहीं है ना? Doctor said if there is increase in the bicarbonate or alkali, okay, it is known, it is called as base excess. So basically, what is happening is that a base is a substance, it's an alkaline substance which is present in our body, okay, and which accepts hydrogen ions to neutralize. Simple. That's your base. Okay? And alkalosis is a physiological state in which there is normal base present. Okay. So let's look at this. Base excess follows bicarbonate or the blood gas. If your bicarb is high, what will happen? Base excess will be high. Simple. तो जहां आप base excess high देखेंगे, तो इसका मतलब है आपका bicarbonate content बढ़ा हुआ है. ठीक है? That is base excess. अगर base excess less than 4 है, so that is metabolic acid. If your base excess is more than +4, sorry, less than -4, तो वो indicate metabolic acidosis को करेगा, और base excess more than 4 है, तो वो metabolic alkalosis को करेगा. अगर आपकी base deficit है, तो क्या है? Acidosis. अगर आपका base excess है, तो क्या है? Alkalosis. जब bicarbonate, जब हमारी gas exchange होती है, तो what happens? What happens to the PCO2? PCO2 किसके साथ combine करता है? Water के साथ? What is the product? Carbonic acid. Carbonic acid dissociates into. So what happens when there is carbonic acid production? What does it stimulate? The brain, right? The medulla. ठीक है ना? आपकी carbonic acid जब produce होगी, bicarbonate ion और H ion जब combine होंगे, they will produce carbonic acid. Carbonic acid will stimulate the medulla oblongata, your respiratory center, and tell you hyperventilate because you need to get rid of this CO2. Right? So it is very important to have this hemostasis or to have this balance because that balance decides whether you are hypoventilating, you are hyperventilating, and what you need to do with the ventilator. Okay. Okay. So I think basically I wanted to थोड़ा सा discussion कर लें, फिर definitions देख लें. Can you help me? So what is acidosis? Acidosis is a process by which your pH tends to decrease or there's loss of bicarbonate. ठीक है, simple है. Acidosis सबको पता है what this is acidosis. Next, alkalosis. A presence of process by which your pH tends to be high, ठीक है, and loss of bicarbonate. Excellent. Yeah. Huh? Yeah. इसको check करो. अच्छा time ले रहा है. Okay. And when you have increase in the pH, right? What happens to your hydrogen ion? Increase in pH, high pH. So it's a balance with your hydrogen ion and your base, your alkali in the body. That is simply what we call as acid-base balance. Normally हमने discuss कर लिया है pH 7.35 to 7.45 है. So ये balance between the acids and the bicarb in our body is what is simple acid-base balance. ठीक है जी? So here it is acidemia and alkalemia. ठीक है, आगे चलें. So when we talk about acidosis and alkalosis, what are the compensating mechanisms? अगर एक patient को एक baby को acidosis develop होता है, what are the two main components of somebody from the Explain. So you have a metabolic compensation and you have a respiratory compensation. Your respiratory compensation is lungs, and your metabolic is kidneys. So your distal tubular is responsible for either Excreting the HIN or absorbing the bicarb, right? Or getting rid of the bicarb. And your lungs are responsible for getting rid of your excess PCO2 or, for that matter, hypoventilation to retain the PCO2. Respiratory acidosis होगा तो क्या होगा? PCO2 exhale out होगा, right? You hyperventilate and you get rid of the PCO2. और kidneys के level पे क्या हो रहा है? Distal tubule पे आप bicarb absorb कर रहे हैं because you want to compensate. But it is not necessary that the body will always compensate. In a sick neonate, the body fails to compensate because of hypoxemia, hypotension, sepsis, metabolic acidosis. That is why we talk about these things. Okay. So purely we are talking about respiratory here because that is more contextual to this workshop. But of course, you can talk about acute kidney injury and metabolic acidosis and inborn error of metabolism. But we are focusing here on the lung. Okay. Okay. So let's talk about this.
Yeah.
Discussed on that. So these are the 4 things that you see in a pH, right? Metabolic acidosis, metabolic alkalosis, respiratory acidosis, respiratory alkalosis. ऐसे ही है, ठीक है? तो आप अगर देखें metabolic acidosis में HIS को क्या हो रहा है? Increase हो रहा है, ठीक है? pH क्या होता है? Decrease, inversely proportional होता है, ठीक है? Primary defect क्या है? Loss of bicarb. Remember that, ठीक है? We're talking about metabolic acidosis, loss of bicarb. And what will happen? Compensatory response क्या है? Hyperventilation. ठीक है? If you look at metabolic alkalosis, आपका hydrogen ion is decreasing. ठीक है? pH को क्या हो रहा है? बढ़ रहा है. Inversely proportional. Primary defect more bicarbonate. ठीक है? Compensate क्या होगा? Alveolar hyperventilation. ठीक है? So basically what you're doing in metabolic acidosis, metabolic alkalosis is compensatory response, which is either alveolar or in case of respiratory acidosis, it is more to do with the kidneys. ठीक है? अगर आप ऊपर देखें metabolic acidosis, metabolic alkalosis, the compensation comes from the lungs, and your rates go up and down, and your minute ventilation goes up and down. ठीक है? And if you look at the respiratory acidosis, क्या होता है respiratory acidosis? CO2 बढ़ जाता है ना, ठीक है ना? Primary day CO2 बढ़ जाता है, और CO2 बढ़ जाता है तो आपके pH गिरता है, PCO2 बढ़ता है, आप retain करते हैं bicarb को from the kidney to buffer that CO2 which has to combine with the bicarb and produce the carbonic acid which will dissociate into carbon dioxide. ठीक है? So respiratory alkalosis, again the same phenomena. आपकी HIs कम है, pH बढ़ा हुआ है, primary defect आपका PCO2 है, और respiratory alkalosis की कोई condition? किस condition में respiratory alkalosis हो गया? हाँ? Urea cycle defect. Respiratory acidosis? Sorry? CNS involvement. So if your brain, if you have a musculoskeletal problem, or you have a brain hypoxic injury, or mostly not hypoxic injury, severe hypoxic injury when your brain centers are not working, then there will be hypoventilation and PCO2 will be retained. ठीक है? तो हम कहते हैं ना central cause है या peripheral cause है, right? ठीक है? और जब हम central cause की बात करते हैं तो PCO2 retention होना शुरू हो जाता है. This is how another obstructive phenomena है, तो PCO2 retention हो सकती है, but it responds to your management. अगर central है, it will not respond. ठीक है? Next. All right. So इसमें आपको दबाना. This is Winter's formula. How do we know compensation हो रही है या compensation नहीं? So there are formulas which, if you want to know, are good. They tell you whether the compensation is taking place or not taking place. And if you look at the metabolic acidosis, meaning there is increased amount of H ions and less amount of bicarbonate, right? In that condition, this is a formula which is your PCO2, 1.5 multiplied by bicarbonate plus 8, which is plus minus 2. So for every 1 millimole decrease in bicarbonate, the PCO2 will fall by 1.25 mmHg. ठीक है? अगर किसी को maths पसंद है या calculations अच्छी लगती हैं, these are good formulas to see if the child is compensating or not. Similarly for metabolic alkalosis, ठीक है? What is metabolic alkalosis? क्या बढ़ रहा है? बाइकार्ब बढ़ रहा है, ठीक है, किस कंडीशन में मेटाबॉलिक एसिडोसिस होता है? Vomitings, you lose electrolytes from the blood, ठीक है, diuretics, ठीक है, pyloric stenosis, ठीक है, so you're giving a lot of diuretics to the child, baby is losing electrolytes from the blood, and you have a condition which is known as metabolic acidosis, ठीक है, so sometimes when you're giving bicarb to children on ventilator, ठीक है, then you can have a condition which is metabolic acidosis, which starts to develop with chronic ventilation. Okay? And always remember the compensation of the lung is immediate. When you see compensation, lungs compensate immediately because of the carbonic acid, a stimulant for the brain. They respond. But the metabolic does not take place quickly. It is chronic. It can set in from 12 hours to 5 weeks. While your acute respiratory component is going to respond immediately, within hours. We don't know why that happens, but there is a system in the body, that's a whole new scope. But basically, it takes time for it to recognize and compensate for the metabolic issue. Because always remember, kidneys will take time. Okay? But the respiratory is going to do it immediately. Next. So, wanted to just go through some basic concepts ताकि हम जब बात करें कि किस तरह से इंटरप्रेट करना है, तो सबसे पहले आपने किस चीज को देखना है जब आप इंटरप्रेट करते हैं? पीएच, वेरी गुड। पीएच क्या हो सकता है? हो सकता है सिंपल, वेरी गुड, एक्सीलेंट। नेक्स्ट किस चीज को देखना है? पीसीओ2 को देखना है। पीसीओ2 क्यों देखते हैं? व्हाट डज इट रिफ्लेक्ट? Very good. It reflects ventilation. I did not use the word oxygenation. I use the word ventilation. जब RDS होता है तो क्या देखते हैं हम? PCO2 देखते हैं, बढ़ावा होता है क्योंकि आपकी वेंटिलेशन नहीं हो रही है। अब PDA की वजह से वेंटिलेशन नहीं हो रही है, शंट की वजह से वेंटिलेशन नहीं हो रही है, इस पे हम नहीं जाते। हम सिंपली बात कर रहे हैं, जब आप ABG की इंटरप्रिटेशन करेंगे तो आप PCO2 को देखेंगे तो आपके जहन में क्लिक होना चाहिए, oh, this is lung, not oxygenation, just ventilation, because that is going to help you in managing your ventilator and deciding surfactant देना है नहीं देना, ventilate करना है नहीं करना, कितना हाई फ्लो पे उसे रखिए या फिर हम सीधा रखें, ठीक है? So remember, diagnosis and management is not with one thing. Don't be tunnel vision. Keep your minds open, connect the dots. हम क्या करते हैं? वो गैस में PCO2 कहाँ आ गया? हमने डोप नहीं किया, फटाफट ब्रेक बढ़ा। So connect the dots. Look at the patient. What is the breathing effort? Is he breathing well or is he hypoventilating? What is happening to your ventilating strategy on your vent? डोप करा है आपने, देखा है कोई ऑब्स्ट्रक्शन तो नहीं है, PCO2 क्यों अचानक से बढ़ता है? डिसलॉज ट्यूब तो नहीं है। तो बेटा ABGs जो है ना, it's a beautiful way to manage your patient and to ensure that you have covered all corners. ठीक है? So remember, PCO2 means ventilation. Next. So थोड़ी सी values हैं, 19-20 हैं, कोई ज़्यादा फर्क नहीं है, but still it's important to know them and to have them, posted in your units. It's a good idea. आप देखते रहेंगे, आप prepare करते रहेंगे. So basically, term newborn 7.35 to 7.45, preterm 7.25. Venous sample slightly higher than the arterial. You know why? The pH is going to be high, and capillary is same as arterial. So 7.35 to 7.45. PCO2 की range almost same होगी. Venous sample में जाहिर सी बात है आगे ज़्यादा होगी. ठीक है? Looking at PO2s, PO2s 50 to 80 पे discussion हो सकता है, and I'm sure there are many studies asking you what are you aiming for. हम जब हम PPHs की management करते थे तो pH 7.35 to 45. PCO2 should be somewhere between 35 to 40. Your PO2 should be 60 and not beyond, right? Because oxygenation is a medicine, and you don't want to overdo it, and you don't want to cause oxygen-related injury. ठीक है? Saturations are important. Term, preterm, venous में आपको पता है saturation का कोई role नहीं, it's not reliable. Anion gap is important, and you know what is an anion gap? Anybody? Anion gap? क्या होती है? cations and your anions, the difference between the two is anion gap. You usually do not take potassium in, so your sodium and your chloride and your bicarb are accounted for, and that is in the anion gap. Normal anion gap सबको पता है क्यों होता है, ठीक है? अच्छा, अब bicarb differences जो होते हैं वो प्लस माइनस जो है वो +2 to -2, तो almost same ही इनमें reading, तो major differences नहीं है except the PO2 and for the capillary and the venous. So you cannot assess PO2 in a capillary sample. Okay? Next. So we have looked at acidemia, alkalemia. हमने बात कर ली ना, ठीक है? We have to decide कि ये acidosis respiratory in nature है या metabolic in nature है, ठीक है? Compensation हो रही है कि नहीं हो रही है? All right. And if it is metabolic, persistent, what is the anion gap? Because you know if the body starts to make more acids, such as in DKA, right? Such as in organic acidemias, what will happen? The anion gap will increase because these are your excess acid ions that are being produced in the body, and the body is unable to get rid of it even by not hyperventilating. Okay? Even by hyperventilating, they are unable to get rid of it. Next. So let's look at these two gases. Sample 1 है sample arterial gas है, ठीक है? pH 7.22 क्या है? Acidosis, very good. PCO2 32, is this normal? Low है, अच्छा ठीक है, सही है. PO2 normal है. Bicarbonate lower side पे. Anion gas. So what is this? Very good. Let's see if it's metabolic acid. Good, excellent. Okay, so this is all you need to do. Okay, now let's look at the gas number 2. pH. Very good. Why is it alkalotic? क्या होना चाहिए normal pH? So 7.40 is our cutoff. ये 7.49 है. Definitely alkalosis. Okay. Sorry, let's go to metabolic acidosis. Causes of metabolic acid in a neonatal unit. Quickly, 1, 2, 3. Neonatal unit. Excellent. What else? Shock. Very good. What else? Sepsis, shock. NEC. Okay. What else? Good. IVH. Thank you. IVH, severe RDS, PDA, the duct has opened up, shunting, right? So these are all causes of metabolic acidosis. Good. So now let's look at gas number 2. pH हमने कहा alkalotic है. PCO2 को क्या हो गया है? कम हो गया, है ना? ठीक है. और PO2 कैसा है? Normal है, ठीक है. और bicarb? Normal bicarb क्या थी? 20 to 24, okay? And anion gap बढ़ गया. So what is happening here? Huh? Respiratory alkalosis. ठीक है? Why respiratory alkalosis? Anybody? Hyperventilating. आपका pH बढ़ा हुआ है. The patient is hyperventilating. Nothing is happening to the PO2. That is fine. So it's not metabolic in nature. It is respiratory in nature. This is respiratory alkalosis. Next. So we've talked about this. An acid-base abnormality is present even if either the pH or PCO2 are normal. So your rule is to look at pH. सबसे पहले pH देखेंगे, decide करेंगे इस बच्चे को acidemia है या alkalemia. Simple. ठीक है जी. Next. क्या प्राइमरी डिस्टर्बेंस है? रेस्पिरेटरी है या मेटाबॉलिक है? ठीक है, ये इंपॉर्टेंट है ना मैनेजमेंट के पॉइंट ऑफ व्यू से. आप लंग्स को डील कर रहे हैं, ये सेप्टिसीमिया शॉक डील कर रहे हैं, कार्डियोजेनिक शॉक डील कर रहे हैं, न्यूरोजेनिक शॉक डील कर रहे हैं, हाइपोवोलेमिक शॉक डील कर रहे हैं, या आप रेस्पिरेटरी कर रहे हैं या साइनोटिक हार्ट डिजीज कर रहे हैं. तो आपको दिस इज वेरी इंपॉर्टेंट टू अंडरस्टैंड व्हाट इज हैपनिंग टू द बेबीज बॉडी. तो आप देखेंगे पीएच इसमें बढ़ा हुआ है, राइट? पीसीओ2 बढ़ा हुआ है और पीएच कम है और पीसीओ2 कम है. ठीक है, तो आपका क्या होगा ये इंटरप्रिटेशन कि मेटाबॉलिक है. लेट्स डू इट अगेन. पीएच बढ़ा हुआ है, पीसीओ2 भी बढ़ा हुआ है. व्हाट इज हैपनिंग? रेस्पिरेटरी, ठीक है, एसिडोसिस. और पीएच कम है, पीसीओ2 कम है. pH कम हो गया और मेटाबॉलिक एसिडोसिस, ठीक है, मेटाबॉलिक एसिडोसिस, ठीक है. Similarly, respiratory, so your top two are your metabolics and your down is your respiratory. So if either the pH or the PCO2 is normal, okay, if your pH or PCO2 is normal, there is a mixed metabolic respiratory acidosis disorder. Can it happen? In what condition? Any condition where you can have mixed? Sorry? RDS में respiratory acidosis, metabolic acidosis हुआ, फिर क्या हुआ? ठीक है, metabolic acidosis हो गया RDS में, इसमें pH को क्या हुआ? pH गिर गया, right? और PCO2 बढ़ गया. ये respiratory है, ये RDS है, सही है? अब यहाँ देखें, ये alkalotic pH है और PCO2 कम हो गया है. You're treating a baby on the ventilator. Your settings are such that your pH has gone up and your PCO2 is going down. So there is now a respiratory alkalosis setting in because you're getting rid of your PCO2. So you need to do something about the ventilator. ठीक है, आपके lungs better हो गए, compliant हो गए, ventilation perfusion mismatch better हो गया है, ठीक है, आपकी जो recruitment of alveoli better हो गई है, RDS dissolve कर रहा है, लेकिन आपने settings change नहीं की, तो फिर क्या होगा? PCO2 wash off होगा, ठीक है, and your pH will go up, तो respiratory alkalosis हो जाएगी, which you don't want because Dr. Azim just mentioned what happens when the PCO2 goes down. क्या होता है? क्या होगा? Reperfusion injury होगी, which you don't want, right? You want to save a unit, but you don't want to give her a 90, do you? No. So understand, so when the baby is on the ventilator, this scenario can happen. Next. So this is important. Is the compensatory response adequate or inadequate? If your PCO2 in a metabolic disorder, you have an expected PCO2 in a metabolic disorder, right? Okay? But if your measured PCO2 is not equal to your expected PCO2, it means mixed disorder. Respiratory acidosis, metabolic acidosis भी हो रही है और साथ में आपकी metabolic acidosis का respiratory alkalosis भी हो रही है. So there's a mixed disorder. So sometimes the body can compensate, sometimes the body is unable to compensate. ठीक है. Next, we talked about this anion gap. ठीक है, और आप सबको पता है anion gap जब बढ़ती है तो हम क्या सोचते हैं? Septicemia, shock या फिर inborn error of metabolism. मतलब बहुत ज़्यादा है and your lung is okay. And usually inborn error of metabolism वाले patient कैसे होते हैं? Hypoglycemic ophthalmia से होते हैं. ठीक है, sick looking इतने नहीं लगते usually they present early. Dehydrated होते हैं, ठीक है ना? उनमें लंग का कंपोनेंट इतना नहीं होता, आप उसको वेंटिलेटर में नहीं डालते, सपोर्टिव ऑक्सीजन दे देते हैं या रूम एयर में रखते हैं, ठीक है? So those are conditions in which there is metabolic acidosis due to inborn error of metabolism with increased anion gap. Normal anion gap metabolic acidosis किसमें होता है? We have metabolic acidosis, but the anion gap is normal. RTA, renal tubular acidosis, very good. So again, interpretation. They say you translate your knowledge into clinical practice. This is knowledge, but you need to translate it into the disease. If you're able to translate it into the disease, then you're able to have the right approach and management. Okay? Okay, next. So we talked about high anion gap and normal anion gap. Next. So let's go with the scenario. Okay? Any volunteers? Come on, yeah, this is learning. I'm also learning. You are also learning. This is not an imtihan. We are adults, we continue to learn. Don't be hesitant.
Baby boy, the special age of 29, 8.1 kg on birth, intubated at the time of birth due to severe respiratory distress. According to these boys, 70% is surfactant given as the protocol on 1 hour of life. Planned to extubate today, but the baby has poor activity despite no sedation. Blood gas shows the pH is 7.13, PCO2 is 68, PO2 is 72, the bicarb is 14, the base excess is -9, and the saturation is 94%. So the pH is 7.1, which is
Lovely. It's acidosis. All agree?
Yes. Then the PCO2 is 68.
What is that? Respiratory acidosis. If we look at the PCO. Excellent. What else?
So the PO2 is 72, which is normal. And the bicarb is 14, with the base excess is -9.
What is happening? There is a respiratory acidosis with what is happening to the bicarb? It's low, right? So alkalosis is developing, right? And your saturation is normal and your base excess is -9. So क्या मतलब है? आपके पास बफर कम है या ज्यादा है? बफर कम है, ठीक है? तो ये compensate कर रहा है? नहीं. So you got your respiratory acidosis which is not yet being compensated. Maybe the baby is not peeing. Maybe there's kidney injury, maybe it's a very dehydrated baby who's going to be the second or third day of life. Okay, has bad lungs, ARDS, RDS, okay, pneumonia at the same time, is not being well perfused, and his kidneys are not functioning, so yet not compensate. Okay.
Excuse me, Vikram.
Questions for me. Excellent. Thank you.
Vikram, can you hear me?
Thank you. Next. Who's volunteering for the next?
No, Vikram, can you hear me?
Can we have equity? I want one scale. Thank you.
Can we go back to the first blood gas?
On 2 hours ago, when we kept on CPAP, 25% F5 and this is 6 milliliter of paragraph suggestive of the grade 1 RDS. Blood gas shows pH is 7.20 and it shows the acidosis and PCO2 is on higher side. And PO2 is normal limit and bicarb is normal limit 24. Oxygen saturation is 94%. Shows the acidosis
And trying because your bite, but at present is it compensated?
Why? Because the pH is not normal limits, it is not uncompensated respiratory.
It's not compensated. And in this, the baby has respiratory acidosis, which is not compensated. Excellent. Can you go to the next? So conclusion, I just have one scenario, I don't know very well, we'll see. So the blood gas measurement provides reliable assessment of your respiratory, okay, and the acid-base uses. And your PO2, your partial pressure of oxygen. I won't go into the oxygen dissociation and all of that, because that also has an implication on the PO. Try to review the state of the peak, examine the peak, correlate your blood gases to the peak. Okay? Sometimes it might be just an error. Examine the baby, review the case charts again. You're missing something. If your gas and your baby are not correlating, then there's something wrong with the way we are evaluating the baby. Very, very important. So don't jump on numbers. Okay? Then somebody asked me, I was just hearing, the gases कितनी frequently करवानी चाहिए? ये तो बताया ही नहीं. 6 hourly, 8 hourly, 2 hourly, depending upon the condition. Or depending upon the condition of the physician. You are an aggressive physician who wants to know every half hour what is happening to the body. आधे घंटे में मुझे inform करिए gas क्या है, saturations क्या है, ठीक है? Right? I'll call you at night and let me know what is going on. So it's not like that. It depends. You're absolutely right on the condition, on the disease, on the ventilation that you're doing. Non-invasive ventilation, again, this is controversial, I won't bring it up, but does non-invasive ventilation really require blood gases, arterial blood gases, capillary blood gas, plus minus? PPD patient, आपको पता है कि PPD is not going to get better in 2 days. What's the point of repeating gases? Does it have an implication? तो हर डिजीज की अपनी इम्प्लीकेशन होती है, लेकिन डिजीज के साथ आपने अपना बेबी, उसका वेट, उसका जेस्टेशन, उसकी कोमॉर्बिडिटी. A baby who is born to a poliomyelitis, mother who has poliomyelitis will not be a baby who is born to a sterile amniotic fluid. There will be difference between the two. Okay, so just remember, it's not about numbers, it's about the patient. Okay. Next. So this is the last. A baby is on 4 liters of oxygen by nasal carrier and level 2 care and the baby is breathing nicely with a respiratory rate of 55. The arterial blood gas indicates a pH of 7.40, PO2 92, PCO2. Which of the following is most appropriate? Decrease oxygen to 2 liters, continue present management and record the data in the chart, increase the oxygen to 6 liters, give caffeine and amino 5 or amino. Anybody? Right. Either you decrease the oxygen to 2 liters, which is the best thing you can do, or you leave the baby alone. Again, your guidelines in your practice. But you can decrease. So इसमें हमें ना caffeine लेने की जरूरत है, ठीक है, ना amino 5 लेने की जरूरत है, और ना ऑक्सीजन बढ़ाने की जरूरत है. क्योंकि pH आपका ठीक है, PO2 आपका ठीक है, PCO2 आपका ठीक है, ना इसको वेंटिलेटर पे डालने की जरूरत है ना? Right? Next. I think that was the last one. Thank you very much. Thank you for your patience. With my colleagues on online, if they want to contribute and add anything, please do. Increase your oxygen to 6 liters.
Thank you, Shabina. Can I ask you a few questions? Hello, you can hear me?
सर मुझे तो आपकी आवाज आ रही है, लेकिन शायद उन लोगों तक नहीं जा रही.
Acha, I don't know what's going on because there are